Thank you for the introduction. I'm very excited to talk to you guys today about antibody testing and its role post-vaccination in determining the level and duration of immunity. Before we get started, I do have a few disclosures that are shown here. So when we talk about the role of antibody response and humoral immunity in terms of coronaviruses, it's important to understand how the body responds to exposure to coronaviruses. And what has been determined previously is that antibody production is pretty ubiquitous and occurs in greater than 90% of people. And this has been confirmed for SARS-CoV-2 in the Iceland serology study, which was a very extensive study that showed about 91% seroconversion among 1,200 infected patients. This antibody production is a means of protection, and some cross-reactivity occurs from coronavirus to coronavirus, although that appears to be more transient in nature. Antibody protection, despite the possibility for creating antibody-dependent enhancement, has generally been shown to be protective in cases of coronaviruses. And so the antibody production is mostly going to be productive in terms of immunity. And in coronavirus, for SARS-CoV-2, general responses include rapid maturation across IgM, IgG, and IgA isotypes. And these antibodies are produced for two reasons. The first is neutralization of viral infection, and the second is FC-mediated clearance of infected cells. And infection generally results, obviously, in protection from viral infection, but it also, in terms of non-exposed patients, there are reports now of some neutralization activity among both adults and children as well. So a strong role for antibody production in terms of viral protection. When it comes to detecting these antibodies, most antibody tests involve using either the spike protein, the whole spike protein, a portion of the spike protein called the receptor binding domain, or the nucleocapsid protein. The spike protein is the more dominant protein that's used in antibody tests. The first spike protein SARS-CoV-2 tests were described by the Kramer group. They made a heterotrimeric fusion of the spike protein that was stable and able to be produced at high levels. And that has been used quite extensively. The other protein that is used in antibody tests is the nucleocapsid protein. This is actually the most abundant protein of the virus. However, it is encapsulated inside of the virus, and so it's only exposed during infection and cell death. All of these antibodies are predominantly measured using enzyme-linked immunosorbent assays, or ELISAs. However, lateral flow assays are also developed and are gaining in prominence and serve a complementary role that we'll discuss later. When we talk about antibody production during the course of disease, the first thing to note is that antibody production correlates with disease severity. So more severe disease produces higher levels of antibodies. However, mild disease often has higher ratios of spike to nucleocapsid protein, which is expected given the fact that nucleocapsid proteins require cell death, and more severe death or more severe disease results in more cell death. IgM and IgAs are produced robustly regardless of the severity of disease, but IgGs are produced at slightly lower levels in severe disease, and the production of IgG takes longer in non-surviving patients. And so there are slight differences in antibody production based on the severity of the disease, but overall, a pretty robust antibody response. When we talk about the duration of these antibody responses, there have been conflicting reports on how long antibody duration lasts. Most of the, or some of the early reports brought up that antibody duration may not be long, and this is probably due to the fact that antibodies do decline slightly over the first 1 to 3 months, and IgA and IgM antibodies decline more quickly than IgG antibodies. However, recent reports have shown that antibody levels remain relatively steady through months 3 through 9. And this all supports findings that were seen in SARS-CoV-1, where antibody levels remain steady for 1 to 3 years following infection. And so overall, the duration of antibodies appears to be pretty steady in terms of infection. The reason for the production of these antibodies is to protect against viral infection. And one of the main ways that antibodies can protect against viral infection is through neutralization of the virus. And these antibodies block the ability of SARS-CoV-2 to infect cells and replicate. Neutralization can be reported in a number of different ways. The most relevant way is through a live virus infection, actually using the live virus. However, there have been pseudovirus infection assays that have been developed, and even assays to look at the disruption between the receptor binding domain and the ACE2 protein. There are strong correlations between each of these three assays, and there are also correlations between antibody production and virus neutralization. So correlations between antibody production and the blockade of ACE2 binding, and as well a correlation between ACE2 blocking and viral neutralization. And these neutralizing antibodies also persist for months, just like the total antibodies that are measured. And so overall, antibodies are a strong component of protection against subsequent reinfection. And this mirrors what was seen decades ago with challenge studies done with the 229E coronavirus, which led to complete resistance to reinfection up to a year later and a blockage of viral shedding as well. So up until now, we've talked mostly about antibody responses to infection, but we're all focused on what are the antibody responses to vaccines. And obviously, there are some differences between infection and vaccines. Namely, the first is that the vaccine is going to occur in a different site than infection. Infection is going to occur in the lungs and mucosal tissues, whereas vaccination is going to occur in the intramuscular space. The immunogen is different between these two as well. Most of the vaccines are using the spike protein, whereas infection is going to be a combination of spike protein, nucleocapsid protein, and other non-structural proteins as well that are produced during infection. And then finally, the duration of antigen exposure is going to be different. Infection is going to expose antigens for a longer period of time than vaccination, although depending on the vaccination, the antigen exposure time will be different. And there's also some vaccinations that have multiple exposures, which is also different. So all of this put together means that there are unknowns in terms of how the antibody response will be different from vaccination and infection. But what is known is that all vaccines that are being distributed now enhance both antibody production and virus neutralization in the short term, and that these antibody levels generally correlate with virus neutralization. So there are similarities in that antibody production generally is going to correlate with protection against the virus. So if we start to go into the individual trials, we first look at the Pfizer-BioNTech vaccine. We can see that before immunization, antibody levels are generally low, and the kinetics of antibody response increase over time with significant differences by day 22 and a sort of a peak plateau being reached about 28 days post vaccination, and that these levels correlate pretty well with the seroconverted patients who are infected. And this occurs across all age groups and dosing that were tested. Moderna, the Moderna vaccine is very similar to the Pfizer vaccine, whereby by 15 days you see a significant increase in antibody production, and it sort of maxes out at around 4 to 5 weeks, and viral levels or antibody levels correlate well with viral neutralization assays, and they also correlate well with the amount of antibodies that are produced from convalescent serum samples. Moving on to AstraZeneca, you see more of the same. Antibodies increasing relatively rapidly, following the same kinetic pattern, and also matching the seroconverted convalescent plasma samples. Johnson & Johnson has a slightly different dosing structure and reporting structure, but still antibody production is robust. It occurs, we don't have the 14-day, but by 28 days we see high levels of antibody production across almost all the age groups. There is a slight difference in the older age group, but in general, high levels of antibody production as well. Sputnik V, no time course, but robust antibody production, significantly higher than the placebo group across all age groups as well. The Sinopharm vaccine does have kinetic data. We see the same kinetic pattern as we see with the other vaccines. It's independent of the dosing as well. And finally, the Sinovac vaccine, also a more limited kinetic profile, but we see increases in antibody production across all treatment groups. Some slight dependencies on the amount of vaccine given, but overall, the general trend is that antibody response occurs relatively quickly following vaccination. It's robust and it correlates with protection from a neutralization of viral infection. However, one of the remaining questions is how long do antibodies last? If you remember back, the duration of antibodies that are produced following infection are quite stable and correlate very well with neutralization across almost all patients. And fortunately for us, we have some new data. It's only from the Moderna trial. It's from their 100 microgram dose group in 34 volunteers. And what we see is similar stability in the terms of antibody levels that were detected and the correlation with neutralization. Now, this of course is only one of the vaccine trials. There's no other reports published as of right now. However, given the similarities in antibody response across these vaccines, it could easily be hypothesized that there will be similar levels of durability across all of the vaccines. In order to test this going forward, we need to think about what are the best antibody tests and what are the proper uses for these antibody tests in terms of monitoring antibody response. And the most widely used tests are ELISAs, and there are several common and widely used commercial assays. They have been analyzed individually and compared head-to-head. I'm showing data from the Oxford National SARS-CoV-2 Serology Assay Evaluation Group. And their head-to-head comparison of many of these tests showed that all of them are highly accurate. They have sensitivities that range from 93% to 99% and specificities from 98.9 to 99.9%. And in fact, the group reported that by slightly altering some of the parameters, all of the tests can produce 98% sensitivity and specificity. And so these ELISA tests are very robust. They've been used to gather the data that we've seen for both infection and monitoring the vaccines, and will continue to be used going forward for these. But they are laboratory-based tests, and there are some limitations to laboratory-based tests. The logistics of testing large amounts of samples we've seen in terms of the molecular tests can be challenging, and it also the availability can be limited in lower resourced areas or rural areas. And so there needs to be alternatives as well. And one of the alternatives are lateral flow assays. And lateral flow assays offer the ability to measure antibody levels at the point of care. And so you have greater flexibility in terms of who gets tested and where they get tested. However, the lateral flow assays historically for SARS-CoV-2 have had a checkered history. And the early lateral flow assays, there were some that received EUAs that ended up not having the necessary specificity and sensitivity that were required. The FDA has gone back and reviewed these and removed some of the EUAs, and so the current EUAs have demonstrated higher sensitivity and specificity. But even still, the literature on these is a little bit variable. I'm showing data from Johns Hopkins group, though, that show that there are lateral flow assays that can perform equivalently with ELISA tests. But the general consensus remains the ELISA in terms of accuracy is going to be higher than the lateral flow assays. But the lateral flow assays have sufficient performance characteristics to be used in specific point of care settings. In addition to these formats, there are also alternative antibody detection methods that are being investigated. One of them has a FDA emergency use authorization. It's a neutralization test from GenScript called CPAS. What it does is measure the disruption of the ACE2 RBD interaction. And it is the closest correlate to live virus or pseudovirus neutralization assays that is available without needing a BSL 3 or 4 laboratory. So it has potential to really be useful in terms of providing a good surrogate for neutralization assays. Our group and other groups are also looking at using combinatorial chemistry to map more specifically the epitopes that patients' antibodies are binding to, with the goal, you can see in the data on the right, being to identify public epitope domains that can be used to differentiate antibodies specific for SARS-CoV-2 from those from similar coronaviruses, and with the goal being to increase the specificity of antibody tests and decrease the number of false positives as well. So with all of that being said, the role of antibody tests going forward, I see 3 areas where antibody detection is going to be very helpful. The first is assessing community immunity prevalence. As we progress in delivering more vaccines and trying to control outbreaks, understanding the level of immunity from a community perspective is going to help to not only be able to respond to outbreaks but also to understand where new outbreaks may be likely to occur, and to dedicate resources to help curb that through increased vaccinations and information. The second role is we kind of talked about that a lot of these vaccine trials have published great data and they are very effective, but the information we have is limited in terms of how long these vaccinations are effective for. And so antibody testing will provide a very valuable resource in monitoring the duration of immunity, and then also specific groups that weren't tested in clinical trials that will be receiving the vaccine, understanding how the efficacy it plays out in those groups and at an individual level as more and more people are vaccinated. The final area where antibody detection can be helpful is a little bit more abstract, but it's in the ability to provide a tangible measurement to individual patients on the efficacy of their vaccine. We all know that there is skepticism in some groups around vaccination, and And the goal should be to help overcome that skepticism. And one of the ways that antibody testing can help is to give people a tangible proof that the vaccine is working to protect them, and hopefully provide them an incentive to get vaccinated. So with that, I'd like to thank the organizers for the ability to talk to you guys today, and I'm happy to answer any questions during the live Q&A. Thank you.